yet another episode of Orthobiologics for uniting the evidence-based medicine and creating and discussing the evidence about orthobiologics. And this episode particularly will deal about osteoarthritis of the knee. They say what is there beyond NSAIDs and before TKR, and there is a big gray zone which we have because there are a lot of patients who demands a good pain relief without TKR or without surgical intervention. So whenever there is a knee replacement required, there is no doubt that we should go for it. But do we have anything to offer for those patients who do not want NSAIDs and do not want TKR or not eligible or early stage of osteoarthritis? So for that, we have a learned panel. Dr. Darshan is here from Pune, Dr. Jawahar is here from Ahmedabad, and Dr. Madhan is there from Chennai. And I belongs to Delhi. So almost pan India we have speakers. So without wasting any time, I hand over the further conversation to Dr. Darshan, who is from Pune and who is the moderator for this today's session. So welcome, Dr. Darshan, and please take the proceeding further.
Yes, sir. Good evening, everyone. Firstly, I would like to welcome everyone on this webinar. It's great to have this session. Courtesy Karun Jain sir is taking a lot of efforts to promote orthobiologics and various modalities that are essentially offering patients things that are beyond certain surgical interventions. So today's basic main focus is on that uh, aging knees beyond NSAIDs and before total knee replacement. So without wasting much time, I'd like to invite Dr. Jawahar Jethwa sir. He needs no introduction, senior orthopedic surgeon, to start his presentation. It's Doctor.
Sir, your screen is not visible.
Uh, Jawahar sir, I think your mic is on mute. So please unmute yourself, sir.
Right. Now I think you can
Yes, sir.
hear.
We are able to hear you, sir.
Please start your PPT, sir.
Yes, sir. You can just share your screen. So, yes, sir. So now we can see it. If you can make it full screen, I think
Yeah,
we'll be able to view it better, sir. Yes.
Right.
yeah,
Yes.
right, sir. Please go
Now
ahead, sir.
I'm
Go
very
ahead, sir.
much happy that I got this opportunity to share with you some of the ideas of aging knee beyond NCIs and before TKR. And I just bring greetings from my city, Ahmedabad. This is Atal Bridge. So what is very important is that couple of the photograph I have prepared from the AI and couple of from the Google, and I also use AI support in multiple conclusions, but nothing financial. What I'm going to talk about is understand osteoarthritis, then grades of recommendation for various measures, means which measures will be recommended at what level. Then couple of things about obesity, sarcopenia, bone, cartilage, nutrition, exercise, harmful activities, gadgets, and self-efficiency or self programs of exercising, oral and topical medicines, intraarticular injections, prolotherapy, some pain management procedures, ozones, and some braces and support. So in all, we are going to talk about something, but the very important part is we know, as Karun has already said, that ultimately it lands up into total knee replacement. So how you are going to prepare something like obesity, something like vascularity, something like osteoporosis. All these things is a part of before TKR. So this is a slide where I want your attention very much that degenerative osteoarthritis is an inflammatory disease, but it's a typical one because there is no CRP raising. Although it is an inflammatory disease, but this is the only disease where you will see normal CRP. And what happens? When does it start? Patient is having tibia vara since probably childhood, maybe in the adulthood. But the problem starts when there is a micro instability. And that is because of the muscle weakness. So once muscle weakness happens, then there is micro instability, then the deformity plays a bigger role. And that is why you are not getting, even if there is a tibia vara, you are not getting any problem before 40, 55 years. And some of the patients having a very old age with tibia vara, they are not having problem because the stability is there. And those are the times where wear is more than repair. One more thing which has been very well documented in literature is low volume and viscosity of synovial fluid with the age 30. So once you pass age 30, this viscosity of the synovial fluid and volume, there is a cartilage loss, there is meniscus thinning, and at the end there will be kissing bones. So what is very important as a prevention or what can be done is the lack of exercise and drying of synovial fluid from age 30. These are the two important aspects which you have to taken care of. Although with that you have to check about comorbidities, obesity, autosarcopenia, malnutrition, rheumatoid, everything. But again, it is the micro instability which start because of the deformity or whatever the reason or degenerative. As long as there is a stable joint with all good tone of muscles, it will not happen. Look at this. There is a degenerative osteoarthritis, but this patient is 68 years with a marked tibia vara, but no major sign of osteoarthritis. So instead of learning which medicine works which way and going for so many papers, it is a time to understand from those patients who are having tibia vara but not having osteoarthritis. So what exactly is that? And that is what is the interest of the newer researchers to find out that how it can be so much without any frictional osteo or degenerative osteoarthritis. So my pattern of this talk would be something like measures, then what is the published information, and what do I do in my practice? What is our opinion? And I'm going to include some of the references from the 2019 rheumatoid arthritis and 2021 the management of osteoarthritis AAOS. That is an evidence base, a very good total recommendations. The first thing is exercise, supervised, unsupervised, aquatic. It is basically to strengthen the muscle, to improve the range of motion, and to enhance cardiovascular health. It promotes weight loss, and as well as it is a neuromuscular benefit which increases the balance of the coordination because all muscles are having a good. So what is it? It is strongly recommended. It is on top of the list, even before, even after TKR. The top of the list is this. So what do? We give so many demonstration. We have a handbills, we have a QR code for which they can find out various exercises on the net. The second part is the healthy muscles, ligament, cartilage. All these things are very important. You should have a healthy all the tissues and enhanced synovial perfusion, which is very important. For which you have to see that there is a increased stability. What is STO and TCVO? It basically increases the stability of the joint and it prevents falls. It is not only the weight bearing axis, but it is also for the stability of the joint. And we always say that we refer to the center for only for learning, and then they have to do lifetime. It is not like they do 15 days of exercise and they come back. And they have to remain, or we all have to remain updated with the new physiotherapy, whatever is coming up, and yoga and increases flexibility and everything. That is also very part of it. So try to understand and advise accordingly the which yoga is good or which yoga is to be not to be practiced. Now, it is consistently recommended, irrespective of all newer methodology and medicines and everything. So, what is to be start first is start with hamstring. The moment patient is having an osteoarthritic type of complaints, hamstring is a very important. They do not allow any FFD, confirm in follow-up visits, and usually what we say that you have to take this tablet after meal or before meal. Here I say take this tablet 15 minutes after exercise. So he has to do exercise because without exercise he is not going to get the results. So the dosage should be related with the exercise whether you have done it or not. And the third part of the exercise is something like restriction of certain activities, avoid impactful activities, then repetitive things which is because of his job or whatever he is doing, which heavy lifting, that also you have to try to control. Weight should be normal and do not use joint like for a longer time, like a very long trekking and all those things. And protective measures are very important. So sustained weight loss is strongly recommended. That is what literature says. That is very, very important. What is very important in my practice is that allow squatting as long as is possible. Do not say you stop squatting. As long as possible, please do it. And sitting cross-legged on bed or not on the floor. This is very important advice, because we want sitting cross-legged, but we do not want them to sit on the floor, because when they are sitting on the floor, when they get up, it is with the weight of the body. But when they are sitting cross-legged on a bed, when they open up their cross-leg position, it is in the air. It is not with the weight bearing. And that is very important. That will keep the motion, all the range of movement perfect, and patient will have a good perfusion of the joint. Education is very important. All guideline, all management like heat and cold therapy, and all behavioral strategies like going very fast up and down on the stairs, and group participation is also very important. As I said, the weight and management of the nutrition. So this is most effective when it is tailor made, and we encourage a personal trainer, educator. So what is happening is, now with the physiotherapy, there are multiple gadgets which are coming up, non-invasive, and patient says, should I take this and that? So what are the things which I'll just explain in my later talk? But there are some of the things like laser therapy, TNS, and pulse electromagnetic therapy, extracorporeal, all have a limited evidence. So limited evidence decreases NSAID in some, but it is not harmful. That is why they are continuing. We do not encourage high price packages at physiotherapy, because they are making a big business out of it. They have 40,000, 60,000 also packages. We do not encourage patients for that. Now let us see what is the published science. So in this talk, if it is a yellow one, that means it is recommended limited. If it is a orange one, moderate. It's a green one, strongly recommended. But if it is a hot red, that means it is strongly not recommended. So let's go one by one. Lateral wedge insoles, now strongly not recommended. We ask the patient, but they do not wear it. So there is no need to compensate varus with the lateral wedge on the sole. Canes, yes. Canes is something which is moderately recommended, and it is very important during morning walks, and particularly while crossing the roads where they go little hurriedly and they go little sideways also, and during the stairs. Braces, yes, braces is also very good, particularly when they feel that it is increasing the stability. Again, the point is of stability. So many patients feel security, pain relief is there, better stamina is there, especially while on tours. Because on the tours, they have to go with the tour guide. And that is why if they ask you ask them to wear these splints and braces, it will be more protective. Oral dietary supplements, salt, turmeric, ginger, and glucosamine, vitamin D help. All these things are helpful. There is a limited recommendation, but many patients feel better, but not all. Now, what is very important with the ginger, turmeric, and all those things is basically good digestive system. Those patients having a good digestive system will be having less pain, because it's directly related to the repair process. So you should not be having constipation or problem with the digestion. Regarding the topical treatment, this is something very, very important, yet an absolute observable part of the science. We know the topical management, I don't know how it works, but it is strongly recommended because the evidence says that all patients are very happy. So it's exceptionally majority are very happy. So we do not go into the detail of how much actually serum level of the diclofenac occurs when you give a diclofenac gel. That is not the point is that patients are very happy. And that is why AAOS has recommended that it is strongly recommended you please use them. They feel much better. Supervised exercise, as I told you, it is good, strongly recommended, but no exercise is not good. That is very important. If patients say that I do not do, that is not good. Ask them. So for consistency, we advocate learning them and performing in group. Many virtual reality programs now available with AI, with the all these lenses and all those things, where you can get a virtual guide for the exercises. Neuromuscular training is again very important, and we advise like yoga, which is very, very important, and light games, where once you have a good balance skill and coordination, that will prevent much of the fall and other injuries, and that will make the joint very much stable. Self management is something, while it is learned by the patients, and medication is there is a compliance with the pain management, with the pain coping strategies and joint protection. It is strongly recommended. The problem is that it is a individual training program. It is not all patients cannot afford, and it is only available in the major cities. Patient education is very important, where you have multiple things like DVD and handouts and all those things is strongly recommended, because unless you teach the patient, it is not going to be the only with the NSAIDs or medicines or topical. What we do in our waiting room, we have multiple videos which goes on. Even if the patient is not osteoarthritis, they also see, learn, and try to find out something from that. Weight loss intervention, which is very, very important. It is moderately recommended. They say that it does not make much difference, but yes, it is recommended, because unless the overweight is not controlled, you are not going to get the desired results. So we strongly recommend and discuss every visit that have you done anything for that. Now the problem is, when you say you go to some experts where you can reduce your weight, they are not willing, they are reluctant. So try to understand couple of things and try to explain to the patient that these are the way you can reduce your weight, something which we have to learn and we have to pass on to the patients. Manual therapy, all this massage is having a limited recommendation, because it's all passive thing. It may cause soreness of the muscles. Laser treatment, okay, it is giving to some patient good, but it is having a limited recommendation. There are no good data available. Newer version of laser have become attraction for the patient, because every time they feel like a new machine has come up, but not feasible for to use for a long time because of the cost and daily visits. Acupuncture again is very well documented in our PubMed whole library, with a limited evidence, may improve pain function. We discourage, because we do not say that there are chances of infection and other problems, so we do not recommend to go to the acupuncturist. Then TENS, yes, that is also good, but having a limited evidence. And physiotherapy always adds this modality, because they want to show to the patient that multiple things are going on. Now, extracorporeal shock wave has its own place, and there have been so many publications with limited evidence. In Ahmedabad, it is expensive, and it is called pulse electromagnetic field therapy. Now, it is something different. I just going to explain to you what is it which has come up. Is called pulse electromagnetic field therapy. It is called PEMF. It is called cytotron, which is very much popular in Malaysia. It is a low MRI machine which can put patient is under that, and it gives so many signals, electromagnetic field, by which there is a less inflammation and some good pain relief, but there is a limited evidence. Oral NSAIDs, we all know, is a good efficacy. It is strongly recommended if not contraindicated. It's not like you do not, but the newer one like palmacoxib is more safe after as a sustained or maybe a chronic consumption of this. But what I prefer is etodolac, which is chirally pure. Now this is a fantastic molecule, not eterocoxib. I'm talking about etodolac, which is a chylipropyr, which is from the MCure, and it is an NSAID which has got the least side effects. That is what is very important. Oral acetaminophen, we all know it is good, strongly recommended if not contraindicated, good for initial stages, and often prescribed with additional medications. Now, what is very important nowadays, not recommended, is narcotics. We do not keep the patients on that. Tramadol and all those things, literature is now no. It does not improve pain or function. It is simply just neglecting the pain. So we prescribe for a short duration, fewer side effects with the patients. Now this is very important. Patient might say that I get some vomiting, I get some headache with the tramadol. But if the patient is having a habit of tobacco or alcohol consumption, you give freely. Those patients will not be having headache or giddiness, because they are already exposed to tobacco and alcoholism. Hyaluronic acid, earlier all the recommendations were with a limited evidence. Now they have just put one step up. Now they say it is moderately recommended. We use a lot, and we use routinely in grade 1, grade 2, and sometimes in grade 3. So this is at least my favorite. Intraarticular corticosteroids, it is moderately recommended. We do not use in so much, but in overseas it is very common. And there is one brand which has come up with hyaluronic acid with a fast acting steroid. So that also is now officially available where both of the things are together. PRP, yes, PRP also is being used, but up till now there is a limited recommendation. We do not use routinely, and there are multiple preparations are available, so there is some confusion which one is good. But the whole this association and all this group is working a lot on biologics. So many things we'll be able to learn and we'll be able to update day after day when we attend all these conferences. Denervation therapy is having a limited value. So all this radio frequency ablation and unipolar, bipolar and all these things with the thermal ablations, there is not a consistent result. So in few cases we do give a genicular nerve block, but there is some moderate relief and that also for 2 or 3 weeks only. Arthroscopic lavage, never ever, not recommended. It has got no extra advantage. It just mechanically washes out, but it is not having a long term. But after something like tear meniscus, yes, maybe some problem that it may go along with that. Arthroscopic partial meniscectomy only when there is a true mechanical locking. Otherwise, preserve the meniscus. So that is very important, and particularly in young adults. Now, as the title is like before TKR, I have a liberty to talk about tibial osteotomy because it is not a TKR. So only in properly indicated patients with unicompartmental knee arthritis it is good. Bone healing and hardware complications can occur. No significant difference between closing and opening. I mean, closed wedge osteotomy or open wedge osteotomy both are same. Up till now, details it is a limited one. But we do indicate means complain patient with a. I mean, there are patients who have undergone this. We are getting a very good result in some of the patients that they feel like there is probably no need for TKR afterwards. So this is the end of the recommendation as per the AAOS and the other literature. Now regarding collagen peptide 2, what is very important, it is effective. It works wonderfully. When it works so wonderfully that I am asking the patient to take lifetime, daily one lifetime. After about 20-30 days, there is a good analgesia. Those patients who are not getting result, I say they stop it. It is not for you. The problem is with the cost, with the duration, and the quality of the basic material. All companies claim that the raw material is from here and there, the capsule, tablets, and powders, and various combinations. And there is also a restriction because of the non-vegetarian source. The vegetarian source is available, but it is not denatured. It is a simple collagen peptide, so that is not very much effective. Rosy extract, yes, it is very important. Now, what we are still not very much exposed is that there is an NSAID, here it is called flavonoids. So, flavonoids is something which is so important to understand from all these herbal extracts. And that works very well. It also supports cardiovascular system. So, double dose of Rosip had come, and so many patients are having very good. It is up to 1 or 2 grade, but if in 1 or 2 grade of osteoarthritis they keep this joint very much stable, they are able to maintain it well. Now, this Boswellia serrata is also very important. It is again having a flavonoids, and it is something like you call Salai Google, right? There are also so many now reports on our PubMed, and it improves respiratory as well. So it is good not only as a part of anti-inflammatory, but also to benefit the guts. That is also very important. And so there are so many publications. There is a separate lecture which I have prepared with all this literature about the flavonoids. Prolotherapy, not very good, very much painful. So we rarely do it. Ozone, yes, a good big number of people now have started. And earlier, before 3 years, we had some 500 cases in Narendra Modi Medical College where we have given this ozone. And we have found a good one because patient says after 1 week that please give on other side. But there are so many advances which has come up in ozotherapy. So we need to remain updated with all those different gadgets, different machines, different dosages and combination of all those. So visco supplement, I again recommend we use regularly because the synovial fluid quantity and quality decreases after the age of 30. So when you give hyaluronic acid, it becomes, the synovial fluid becomes as if it is the age 30. Now, very important thing, it is a triggering. So remember, the synovial fluid which we are giving is lasting there only for 3 to 4 weeks or maybe 6 weeks. But the effect is for 1 year. The reason is that it triggers the indigenous secretion of hyaluronic acid. Now, this is very important. And with the adding of sorbitol, it has given a fantastic result because it prevents inflammatory reaction to the free radicals. And that is why we are happy. There are so many patients who are taking HA for last more than 14 years, 15 years regularly. Even with this much of tibia vara, with this much of osteoarthritis, which we are seeing on the x-rays, patients is having a full movement without pain. So what is happening, we do not know, but this is the evidence, this is our experience, this is our observation, which works. And I also give sometimes viscosupplement with genicular block with the dots which I have shown you. That gives an immediate relief because patient expect that tomorrow there should be less pain. But it is to be given under IITV to find out those points. Upper tibial osteotomy, yes, all with the implants. But what we have learned in Ahmedabad, we are doing upper tibial osteotomy without implant. So why without implant? What happens? Understand only two or three slides which are now remaining. That cartilage is having a subchondral bone zone, or there is a tide mark. From there, the new cartilage cells are coming up. Now, this is very important. If that subchondral bone part is damaged, it is not going to throw good, healthy new cartilage, I mean chondrocytes and chondroblasts. So that is how it is very important to understand that we keep or preserve that area. So something which is the deeper zone and the superficial zone, there is a connection. And the low friction surface is on the upper part. The lower part, supposed articular cartilage distributes mechanical stresses across the joint and provides nutrition. All these 3 points are very important. So what happens? That we got this from 200 patients with an MRI of helixometry after doing upper tibial osteotomy. And we could find out that subchondral bone plays a major role in stress distribution, stress shielding, and continuous health cartilage. We observed that osteo with implants near subchondral bone may have negative effects on regeneration or the quality of regeneration cartilage, but implant less osteo seems better. And we have found that biopsy after doing a biopsy of that the regeneration is a hyaline cartilage, not fibrocartilage. A big breakthrough in the research of this thing which we have found in our cases. So this is very important to understand that this is a tibia vara where we have done this osteotomy, we have corrected it, but there is no implant. So how do we maintain? We maintain by the external splint. So in nutshell, what I just want to convey is that osteoarthritis is an office orthopedics, so you should know all the measures. Evaluate, screen for early stages, educate, counsel very well, take 15 minutes for counseling, gain stability by proper exercise. Now this has to be lifetime. You try to ask them to, they should learn themselves, they should not depend on the physiotherapist. Simple weight loss results in good pain relief. Minimum NSAIDs, Karali pure atherolac, collagen peptide, glucosamine and other flavonoids all helps a lot. Viscose supplements work very well in properly selected and compliant patient because I say that it is not going to reduce your pain, is not going to heal your, it is only going to prevent the further problem, further friction, further damage. And that is how we have to counsel the patient. And then of course we have to recommend for the TKR. Corrective osteotomy also interventions in selected cases. And do not forget to treat osteoporosis, sarcopenia, muscle weakness, stiffness, all these things works a lot. So I thank you very much for this opportunity. I'll be very happy to answer your questions and thank you very much.
Thank you so much, sir. It was a great comprehensive description of all the various modalities that are available. Karun, so should we take questions now, or should we finish the talk and
I think Dr. Jawahar, you will be available
Yes,
throughout
yes,
the session.
I'm available. Right.
Okay, fine. So, do you allow that we will take the next
Yes,
talk?
I think yes.
Because I really liked your talk. It's eye opener about many products like visco supplements, and
yes.
now we have none other than our who and who of orthobiologics, our own favorite, Dr. Madhan Jeyaraman. So, Dr. Madhan, we request you to please share your screen, and we will have question answer session in the last.
Yes, yes. We'll have questions later. So,
Thank you, Dr.
Dr.
Darshan.
Madan, sir, please, you can start your talks.
Yeah, I think my screen is visible, no?
Yes.
Okay. So let me continue with the second session of today's webinar. It is on orthobiologics treatment in knee osteoarthritis, which is the revolutionizing the joint care. So Jawahar sir has spoken about all the modalities from physical therapy, visco supplementation, so it's joints, pharmacological therapy, then injection modalities, and he touched the surgical aspects also. Now, what I'm going to talk is recent modalities on orthobiologics. So the global knee osteoarthritis burden is an epidemic. We can call it as an epidemic since 1990s. The prevalence is drastically increasing. Now the prevalence is up to 48% of the population. In US alone, 27 million have got affected. The projection rate for 2030, now we are in 2025, so the projection rate for 2030 from right now is 67 million. It is the projection we have expected. So that much of population are going to get affected by knee osteoarthritis if not given a definitive care. So it plays an economical burden also in terms of uh, the health and the hospitalization rate, including the treatment cost, everything includes to the economical burden of osteoarthritis. So it continuously growing. In Australia, the total knee arthroplasty costs exceed 1 billion annually. In US, TKR volume increased by 143% in 2050. So there is a drastic increase in the statistics, which is leading to the bigger minor of the disease called knee osteoarthritis. In Germany, the revisions are expected almost 90% by 2050. So there is a vast potential to intervene osteoarthritis at the earliest stage. The healthy knee contains smooth intact cartilage, appropriate joint space, and normal synovial membrane. But knee osteoarthritic knees contains degraded and thinning cartilage, narrow joint space, bony spurs, and inflamed synovium. So the limitations of the therapies, the conservative approaches are already available. Physical therapies, injections like steroids, hyaluronic acid, all gives a temporary relief, but it cannot halt the progression of the disease. When the symptomatic treatment is applicable only when the pain or inflammation is too much without any cartilage loss. Surgical management comes to play when there is an advanced grade of arthritis along with meniscal tears or ligamental tears. Now coming to the basis of tissue engineering, this is the new dimension of orthopedics called orthobiologics or tissue engineering, which helps to repair, regenerate and rejuvenate the tissue or the damaged tissues or tendon by help of some extraneous factors called stem cells. So first thing is the basis of the tissue engineering are three things: scaffolds, which are the building blocks of the regenerate, and growth factors of the signaling molecules, which induces the stem cells, which acts upon the scaffolds so that it will give a good regenerate, and like finally is the stem cell. So these three things should act in a milieu to give a good regenerative environment for any damaged tissue or a tendon. Now coming to APBOs, there are something called APBOs or autologous peripheral blood derived orthobiologics. We have 10 entities here: PRP, platelet lysate, ACS, that is autologous conditioned serum, gold-induced cytokines, plasma-rich in growth factors, growth factor concentrate, autologous protein solution, platelet-rich fibrin, hyperacute serum, and autologous conditioned plasma. These are all 10 things will come under peripheral blood derived orthobiologics. The ultimate aim of these 10 orthobiologics are nothing but giving rise to growth factors in one or the other form. These growth factors will take up the action and it will act in the particular point of interest to give you a better symptomatic relief. If in the optimum amount, it will give a good region rate too. So this is how platelet-rich plasma is being prepared. At the end of first centrifugation, you will have that three-column concept where the upper column will be removed and it will be recentrifuged to get a PRP. So once PRP is done, when it was put in the slide, the tiny dots of blue color in the PRP slide is representing platelets. So in a PRP, 94% of PRP volume should contain platelets. Then only it is called as an ideal PRP. So one particular study which was published by our Indian author Sandeep Patel from PJ Chandigarh. This is the landmark study which is published in AJSM, American Journal of Sports Medicine. They compared the conventional dose versus superdose PRP for knee osteoarthritis. Yes, they have given a conclusion that single 8 ml injection of PRP with an absolute platelet count of more than 5 billion. So in the suspension of PRP, more than 5 billion is better than 4 ml PRP for early OA. But this study fails to show whether any regeneration happened or not. Next comes platelet-rich fibrin, where we used to have a single centrifugation technique without any anticoagulant. The upper column will form a gel. Out of this gel will be cut at the end, at the demarcation of RBC gel and the plasma gel, and this plasma gel will be placed in the place of interest where tissue has to be regenerated. Out of platelet-rich fibrin, we have different entities. One is called advanced PRF plus, injectable PRF, titanium PRF, and growth factor impregnated PRF. Out of which first three entities are in play. I'm practicing IPRF, which is very easy to prepare and very easy to inject in the place of interest. The next biologic in the current scenario is GFC. There is a kit for GFC. They claim it like, yes, this is the product which gives growth factor concentrate. But to be mechanical and manual, when you prepare leukocyte rich or poor PRP, subject it for the ELISA modality to check for all these growth factors. These are the 5 growth factors which are very important to call that particular solution as a GFC, that is growth factor concentrate. So one paper has been published, serial intra-articular injections of growth factor concentrate in knee osteoarthritis, a placebo-controlled randomized study. This study was from Moradabad, Tirthakar Medical University. But this study also failed to show any regenerate has happened or not. Platelet lysate. This is the next modality. It is derived from PRP and formulated via double freeze-thaw cycle. So this platelet lysate will come in a powder form which can be stored for a long period of time where growth factors can be quantified. There are a lot of literature available, and this is how they used to prepare PRP, and they will do freeze-thaw cycle. Finally, it will become a powder and the powder can be stored. Once the for the optimal use, we can add normal saline or distilled water to make it as a injection. Next one is Goldic therapy, gold-induced cytokine, where I was one of the author. This study was happened in Dubai by my close acquaintance, Dr. Sharmila Tulpule. And we observed the results and we wrote a paper. This comprises of drawing a peripheral blood in a syringe which contains gold particles, lined syringe, which will be incubated in the incubator for 37 degrees for 1 full day. Followed which there will be a filter across. We have to crisscross the filter so that the impurities and the gold particles will be retained, and it is ready for injection. So this study was performed, and here also we failed to show the thickness of the cartilage has got improved. And we tried in an in vitro analysis with my colleague in my college for the antimicrobial spectrum of autologous PRP and lyophilized homologous platelet lysate. We were able to achieve E. coli and Pseudomonas aeruginosa with a good MIC. Thus, we proved that yes, there is a there is an antimicrobial spectrum in PRP and homologous platelet lysate. Next comes to stem cells. Yes, now coming to the main part. There are different modalities of stem cells, different modes of stem cells like bone marrow, adipose tissue, umbilical cord, amniotic fluid, placenta, salivary gland, skin, endometrial MSC, dental pulp MSC, limb bud MSC, peripheral blood MSC. There are a lot of MSCs available in the body, right from head to toe. But as an orthopedic surgeons, we are more inclined towards bone marrow. Now, orthopedic surgeons and plastic surgeons are very well connected with adipose tissue, and adipose tissue have different modalities, different products of regenerative products, which will be helpful in regenerating cartilage or bone. Biological therapy selection, PRP, yes, it is acellular, it contains only growth factor cytokines and has only short-term effects. Bone marrow concentrate, we have less regenerative cells, comparatively it is invasive. Adipose tissue fraction, it has highest growth factor concentration, lot number of cells are there, and there are level 2 and level 1 evidences are available, and MRI scopic evidences are also available. Out of all these things, the main important thing, it should clear Indian regulations. Indian regulation as per new Drug and Cosmetic Act clinical trial rule, we have three things. One is minimal manipulation, substantial manipulation, more minimal manipulation. This minimal manipulation is allowed in India to practice on a daycare setup. What are the ideal conditions for ideal cell therapy for musculoskeletal conditions? It should be safe, effective, and evidence-based approach. No enzyme or culture should be involved. It should be done in the same surgical setting, and it should comply with Indian regulatory standards. And we identified which sources of MSC are very important and good for osteoarthritis knee. The results were increased chondrogenic potential were observed with synovial stem cells, followed by adipose MSCs, followed by bone marrow MSCs. Enhanced chondrogenesis were observed when mixed with chondrogenic factors or amniotic fluid MSCs, placental derived MSCs, umbilical cord MSCs, endometrial MSCs, peripheral blood MSCs, and periosteal MSCs. So this is a review article which shows a good variety of stem cells and the potential for regenerating a cartilage. Now coming to bone marrow, this is my protocol, how I drive bone marrow from ASIS, and I'll subject for differential centrifugation to get the final product. So this is one of our study where we published a non-randomized single center study from our own institute, where we observed we had a this is the baseline on day 0. See the lining of a cartilage, how irregular it is. At the end of 2-year follow-up, there is an increased thickness of the cartilage, which is shown in the MRI final follow-up, and increased joint space in the X-ray. So finally, we summarize this in the form of an article. 72 patients we took, and out of which 63 patients were followed up. So we injected BMAC injection with the 45 million per ml of more than 85% ability. So there were no donocyte mobility, no local reaction, no hematoma, no paresthesia. And we included grades from 1 to 3, and the 4th grade we excluded. And we got a good results in terms of regenerate in form of MRI. And pain relief we have observed with VAS, WOMAC, VAS IKDC in MOCAD score at the end of 2 years follow-up. This is one another landmark study which we did in our institute, where we involved 80 patients for dose escalation study. So this is group 1. Just see the lining of cartilage in MRI. Day 0, this is at the end of 1 year. We infiltrated 1 million cells, 1 million BMAX cells per kilogram body weight for each niece we have injected. There was no improvement in MRI at the end of 1 year follow-up. The next one is group B. Here also 20 patients, where we injected 2 million cells per kilogram body weight. There was a good lining of cartilage at the end of one year. This is third group, which contains 20 patients, where we injected 5 million cells per kilogram body weight. There were a perfect lining of a cartilage regeneration at the end of 1 year follow-up. This is the fourth group. We had 20 patients. We gave only saline as a placebo, where there were no proper cartilage formation was observed, and hence it was put up like this way. Totally 80 patients were enrolled, out of which group A, B, C, D 1 to 5 million cells per kilogram body weight were given in A, B, C respectively, and group D received normal saline. We concentrated only grade 2 and grade 3 patients, where we observed good results with OMAC, POOS, IKDC, and VAS score. So our conclusion was group B and C has the minimal required dose for significant patient reported outcomes in terms of knee osteoarthritis. Hence, we entered the time scale of knee osteoarthritis over globe. In 2014, Chris Santino from US have started, and Salamana have started in 2017. 2020, Lana and Joe Purita have expanded further, and 2021 again Lana and Fonseca has given some good details about BMAC for ONE, and in that timeline we entered in 2024 as an Indian, myself and my colleague Dr. Sathish, we entered as the dose stratification for BMAC in knee osteoarthritis. Next comes the adipose tissue. Why adipose tissue? Adipose tissue is resistant with age, genetically more stable, higher proliferation and differentiation capacity, low senescence ratio, high telomere length, and 500 to 2500 times more pluripotent cells. And 1 ml of lipoaspirate will give rise to 1 lakh to 1 million adipose derived MSCs. So here how we will process lipoaspiration, tissue processing, and SPF administration. These are the 3 steps which will be involved. So SPF is a cellular fraction which contains ECM, that is extracellular matrix, pericytes, where pericytes takes the role of MSCs, and endothelial progenitor cells, B cells, T cells, mast cells, and M2 macrophage. These things will give rise to angiogenesis, anti-inflammation, and immunomodulation. So totally SBF is a cocktail, heterogeneous cocktail of cells where pericytes takes place the action of mesenchymal stromal cells. So how do we isolate SBF? We prepare the canister. So inlet canister, and below that there will be outlet canister also, okay, outlet opening also. We draw from the iliac fossa, we used to draw the site how to drive stem cells, I mean adipose tissue. We won't cross the midline of the umbilicus. Midline we won't cross. With the help of motorized liposuction, we used to do liposuction along with the tumescence fluid. This is the lipid part, this is the tumescence part, where we discard the tumescence and we'll collect this lipid in a adipose tissue in a separate bag. Then this adipose tissue will be subjected for ultrasonication. This is the ultrasonicator where direct ultrasonication will be given into the adipose tissue. It will break into fragments from macrofat to minifat, minifat to millifat, millifat to nanofat, and nanofat to SPF. This will be done in this particular instrument. And finally, whatever we are getting out of the last certification will be sent for injection. This is how we used to inject. So OA patient selection, grade 1, yes, grade 2, yes, grade 3 with caution, grade 4, absolutely no. This is the patient selection for cell therapy in knee osteoarthritis. And this is one such example. This is day 0. This is day after 2 years, that is 24 months. There was a significant pain relief and functional follow-up was very good without any changes for replacement. Now, this is one of the MRI. 52-year-old female with the right OA knee, pre-SPF. Yes, this is the MR cartogram image, which will give an exact thickening of cartilage in 6 places: medial lateral patellar facet, medial lateral tibial condyle, medial lateral femoral condyle. At 6 places, we will calculate the thickness. This is a pre-procedure. This is post-procedure. There was a subtle increase in the thickness of cartilage for 4 mm. Sorry, 0.4 mm, not 4 mm, 0.4 mm. This was the average we got in our study. So this was again summarized in Indian Journal of Orthopaedics, where we have received 231 joints, out of which 115 joints received stromal vascular fraction and 116 joints received saline. So SBF group, there was increased improvement from 43 to 78 in KOOS score at the end of 36 months, that is 3 years. And in VAS, there was a decrease in trend from 8 to 3 at the end of 3 years follow-up. So this is summarized in Indian Journal of Orthopaedics in 2023. So while doing our cell therapy, we used to do a cell count where we have 95% of the live cells and 5% dead cells in the concentrate. And this is the flow cytometry image, and this is the microscopy image where this dots show MSCs. And it's a cocktail, not MSC alone, it's a cocktail. When we compared with bone marrow and adipose tissue derived immunohistochemical markers for CD73, 90, and 105, these three markers are mandatory. When compared with bone marrow to adipose tissue has a better immunofluorescence, immunohistochemistry markers in their tissue. So out of interest, in one patient, we did second look arthroscopy where there was a big cartilage loss, and we did microfracture along with stem cells. There were the patient were able to get, you can see humps and bumps. It is not a smooth gliding cartilage. There was up and down. From the crater, we took one pinch of biopsy and we look it for whether what type of cartilage has regenerated. We could able to appreciate hyaline like cartilage. It is not purely hyaline cartilage, it's not purely fibrocartilage, it is a hyaline like cartilage. It was a mix of hyaline plus fibrocartilage. Next comes to the modality, which includes the cultures. There are a lot of expanded products available. These are all the available products which will take different number of days for different varieties, and there are in different phases of clinical trials which is being updated in the clinical trial registry. For any product, from how this talks about allogenic products, from cell culture isolation to culture, how to reprogram it, how to engineer it, how to expand it, finally characterizing and in vivo monitoring. These are the 7 stages one product will cross across to become a clinical trial product in the market. Now comes to Stempeutics. Manipal company has given allogenic stem cells for clinical use, out of which Cipla is a company which promotes allogenic stem cells for critical limb ischemia. Alchemy is a company which promotes doing post-marketing surveillance for osteoarthritis knee. And one more product from Stempeucell, it is coming for Crohn's disease. Why allogenic formulation? Single stage procedure, deliver target number of cell counts in a desired area. Off-label use we can do. Hypoimmune response we have to anticipate because it is an allogenic product. When you do allogenic product, we have to have a GMP lab for doing all these protocols and guidelines regulation. But there will be a question of safety, efficacy, cell viability, and vitality will be there at end of the receiver, where the receiver receives the product. This is the very big question here. Now coming to our evidences, Prisma compliant meta-analysis for RCTs on knee osteoarthritis managed by allogenic versus autologous MSCs. We found out that autologous sources stand superior when compared with allogenic sources. This is published in Indian Journal of Orthopaedics in 2022. One more study. What is the clinically significant ideal MSC count for knee osteoarthritis? We gave an answer that 5 to 10 billion cells are enough to give a good regenerate. Is culture expansion necessary in autologous mesenchymal stromal cell therapy to obtain superior results in knee osteoarthritis? The answer is no. There is no need for culture. The culture expansion is not necessary to obtain the superior results. That means uncultured autologous BMAC or SPF will do wonders. The next one is, does vehicle-based delivery of MSCs give superior results in knee osteoarthritis? This is also our study. Vehicle meaning any scaffolds are needed or not. We gave an answer no. There is no clinical benefit in giving scaffolds while comparing with the direct delivery of stem cell based products. I can't say it's a stem cell based products. Even regenerative products are hold good without any scaffolds. And we have given one more topic for what are the process variables which impact your concentrate of bone marrow. There are different variables. One is autologous or allogenic source, the choice of anesthesia, site of harvest, clinical centrifugation protocol, coagulant choice, bone marrow aspiration, needle type, and size of syringe. All these things plays a major role once we prepare BMAC. The next one is understanding and controlling the variables for stromal vascular fraction. So these are all the factors. Sources of SPF, it can be from any source, from abdomen, thigh, buttock, any area. Choice of anesthesia, site of aspiration, autologous or allogenic, harvesting tools, isolation techniques, centrifugation protocol, volume of delivery. These are the various factors which impacts the quality of SPF isolation. So finally, we have autologous and allogenic products. Autologous, we have PRP, PRF, BMAC, GFC, SPF, MSC. So many products have come up. Osgro, Cartigro, which I didn't deal here because Osgro is a product which we drive from Regrow company for avian hip. Cartigro is for chondral defects rather than knee osteoarthritis. And allogenic products, STEM 1 we have for knee osteoarthritis. Reagenasip is for critical limb ischemia. So the take-home message here is it is an autologous tissue. Regulatory frameworks and guidelines are very important to carry out any product, cell-based products in the clinics. Standardized protocols to be followed. And here comes the cartilaginous and osseous orthobiologic. If you ask me particularly, osseous orthobiologics is BMAC and bone marrow derived products. Cartilaginous orthobiologics is nothing but adipose derived products. These will give good cartilage. And the large scale RCTs are required, and learning curve is very, very important. These works I have done from past 1 decade to give such a huge evidence in the scientific community. And the future research based upon standardization of dose and frequency of injection, universal protocol and preparation methods and injection techniques, quantification of growth factors, MSCs and cellular components are very much important. Usage of allogenic and autologous is very, very important. Radiological documentation either on bone or cartilage regeneration is mandatory to convince your colleagues, peer colleagues, that yes, it is getting regenerated if given in the appropriate amounts. RCTs are very well needed for conduct. The next one is the upcoming therapies are gene therapy, which is upcoming right now, and MSC derived secretomes. There are a lot of publications have come out in orthopedics. The last modality is extracellular vesicles. We have large EVs and small EVs, where we are more concerned about small EVs exosomes. Here also we have exosomes are nothing but which contains immune factors and growth factors. It is a ultra molecular weight, ultra molecular product which deals with the nanomedicine. Here also our team have explored the regenerative aspects of exosomes in knee osteoarthritis. And in 2022, we have published one more good article on MSC-derived exosomes in knee osteoarthritis. At last, we have concluded that all the stem cell therapy-based products are called advanced therapeutic medicinal product, that is called ATMP. This is a regulatory affairs topic, which has categorized into low risk, high risk. We have different sections for governing all these things. Section 351 deals with regulation of drug and biological products. Section 361 deals with pre and post marketing review requirements of any product being launched in the market. So section 361 says minimal manipulation, already we dealt. Homologous use is nothing but whatever tissue you are taking. For example, if you are taking bone marrow is a tissue. You can manipulate and you can use the same bone marrow for treating bone marrow based disorder. For example, if you are taking adipose tissue, you have to use that adipose tissue for treating adipose tissue based disorder. That is called homologous use. But here we cannot maintain homologous because we are taking bone marrow or adipose to treat a cartilage disorder. So homologous we cannot use here. Homologous can be used only in allogenic products. For example, if you are taking a cartilage, bit of cartilage from a non-weight bearing area, culturing that and storing for huge number of people, then it can be used as a homologous use. Or else same autologous condition also you can use homologous. If for example, if you consider me from my knee, if they are taking a pinch of cartilage from non-weight bearing area, culturing it back and injecting back to my own knees, that is called autologous plus homologous. But if my non-weight bearing area cartilage has been taken to produce lot of chondrocytes, and these chondrocytes are implanted into different persons like A to Z, then it is called allogenic homologous. So homologous has a different meaning, which cannot be maintained in autologous therapies with uncultured ones. The third point is it should not be involved with any combination of cells. You cannot inject PRP with hyaluronic acid, PRP with stem cells, PRP with steroids. All these things are banned because this will become a drug. We have to take drug license. For if you want to inject hyaluronic acid along with PRP, do inject one injection after the other injection, at least 1 or 2 minutes apart. And whatever fourth point is, whatever cells we are injecting into your body, it should not have any systematic effect, or it should not hamper the biology of the primary living cell. So injectable scaffolds for stem cell therapy in cartilage tissue regeneration. This is my collaborator, Dr. Chitra from IIT Madras. We have developed a gel. Now recently everyone is posting up, yes, Germany has developed a hydrogel. Such hydrogels we also have developed, but we have not taken into the clinical trial market because we are waiting the approval from DCGI and ICMR. We have done all preclinical, physicochemical, biomechanical studies with this, and even animal studies are also over for us. Once our regulator gives the green signal, we will start human trials as well. So orthobiologics in orthopedics, we know a little. We don't know so much things, which is a bottom portion of the hidden iceberg. So what we lack is discussions, conferences, training protocols, guidelines, and ethics. If we know all these things, yes, orthobiologics will boom like a big modality to treat a disease in particular point, so that it won't become a pandemic soon. This everyone must have seen this PRP's scam. When we call any orthobiology, not alone PRP, I have put this slide particularly, anything can be called as a scam when we don't use at the appropriate grade of the disease with appropriate quantity and quality, then it is called as a scam. Otherwise, when you take proper patient selection, proper orthobiologic modality with proper ethical approvals, then it is not a scam. So already I have told one study about this dose escalation study where we checked the quality control of BMAC in OA. This has been submitted by these are my Brazilian colleagues. These colleagues have submitted our paper to AAOS guidelines. So soon we may expect that AAOS may release guidelines based upon the published literature. And this is my Delhi and Dubai team and my Indian team who helped me a lot in carrying out the research in this particular area of orthobiologics. Regenerate, rejuvenate, and rehabilitate. This is the mantra for going ahead with regenerative modality. And this is our own fellowship, which we have started for this year. This is a 1-year program with university accredited fellowship. And this is myself, Dr. Madhan from Chennai. Thank you.
Excellent talk, Dr. Madhan sir. I mean, to be honest, it is very difficult to carry out such high level of research. I mean, with all these exosomes, all these things, I mean, it is genuinely something that not many people would expect is actually being carried out in India. We would think that these are being carried out somewhere in Western countries. I mean, I don't know. So it's an eye opener. So I mean, excellent. Kudos to you. Great accolades. I mean, it's astounding work that you're doing, and the number of publications that you just showed is truly phenomenal. And this is superb. And Karun
Thank
sir,
you, sir.
maybe.
Thank you.
I agree. Dr. Madan was at his best, and I really like him as an orthopedic surgeon and a scientist because very few orthopedic surgeons who are scientists also. So
Absolutely,
Madan is
absolutely.
one of the pioneer in that. So coming to few question and answer sessions for the benefit of our audience. So my first question is for Dr. Jawahar sir. So sir, what I have understood by OOS guidelines that HA is not more than of any use than placebo. But now we have variation of products of HA. Like we have hyaluronic acid, which is ultra high link HA, it's a latest product. Then we have stabilizer like sorbitol. Now we have a product which has a mixture of hyaluronic acid plus triamcinolone. So what is your take on that, sir?
So my take is that don't go for USA only. We are students of science. We should learn from Europe also. and thousands and crores of injections are being given. So there is always a two sides of any scientific schools. So try to learn from both sides. Number two is that number of new companies are coming up with product. So it's a logically thinking like it must be something, otherwise they will not pour in so much of money. And the third part is very important, that we now know it is triggering of the secretion of indigenous hyaluronic acid. And that is how it is working for 12 months. And now we know also the quality after giving injection. So, and AOS has upgraded their recommendation. It was not recommended, now they are recommended it moderately. Now it has become yellow. It was not yellow before. And we know there are so many other publications on the Europe which we are recommending a lot. But cross-link, adding couple of things like sorbitol has made the difference, because they do not allow inflammation over the free radicals, by which the pain part decreases very fast. So everything is like, not a one particular molecule, but everything together with the increase in exercise and stability. Very important even in orthobiologics. If the exercise is not given importance, it is not going to be having a stable joint, so it is not going to work. But very importantly, which I found from Dr. Madhan, which is an excellent, I think, must be respected a lot as a scientist, because he has done a work from the base. There are some papers where they have done distraction of the knee joint. Simple. For 8 weeks. External fixator in extension of the knee joint for 8 weeks. And they have published that everything regrows, because there is no weight bearing allowed. There is a weight bearing, but it is through the external fixator. So both articular surfaces are not touching. So that way also we know that body has a capacity. Unfortunately, we talked a lot about non-weight bearing in AVN, but we never ever have any study where non-weight bearing has been experimented. That keep the patient non-weight bearing of osteoarthritis. What happens? Now this is the part where it makes a big difference. And the second part, which I just want to, even if you are not asked, I just want to add to Dr. Pradhan's work, is that probably if you can include relaxometry findings. How can you find out whether it was a regenerated fibrocartilage or regenerated hyaline or hyaline-like? So there are two methods. One is biopsy, but the other method is finding out relaxometry parameters. So T2 images will give you that what is the quality of the cartilage, and there are a number of publications. Now I was fortunate to talk on the dais with a person who had 800 publications only on this. So that is something very important, that without going invasive, without going for secondary arthroscopy, all these things which you are doing can be found out by finding out the quality of the cartilage through the T2 image. Now, if you give me time, I'll just explain what is the basic of it.
Yeah, please go ahead, sir.
The cartilage contains water, and the MRI which is given to the body is revolutionizing all H2O molecules. So energy, when it is given, it goes on revolving. When the energy is stopped, it releases those energy. So the release of energy is controlled by these machines, which is relaxometry. So the tissue which has got more water will be showing less resistance to release of energy, and which is having a less water will be showing more. So by that way, it is very well established in the field of science that we can find out whether this is a hyaline cartilage or a fibrocartilage. And that is what we have worked in about 7 years with the 200 patients with preoperative MRI, 3 months, 6 months, 9 months. And then in 2 patients, we could go with the secondary biopsy and can confirm. So my
So
point
before,
is, sorry.
yeah, please.
So my point is very important, that if you do not give rest after any procedure, if you continue wear and tear, how can you expect something good will happen. So healing requires no further damage. So we should think of that what can happen if we do not allow for tremendous or regular wear and tear of the joint after doing anything which we want. And that is why probably TKR is so well.
So, sir, before I take your question to Dr. Madan,
Mm,
I want to ask a practical point for a general orthopedic surgeon.
mm,
I'm not talking about regeneration or whatever protocol. I'm talking about a patient who is having grade 4 osteoarthritis, has varus. For me, he's an ideal candidate for knee replacement surgery, but does not require knee replacement. So, will you be dare enough to inject HA or any other modality? What is your take on that, and what is the scientific evidence behind it, sir?
Okay.
I'm talking about a patient with a gross osteoarthritis, require varus and require TKR, and but do not want TKR.
Yes. So there is one thing. What I do, I will talk about the science afterwards, but what we do practically, I tell them that TKR is good for you. If you are very lucky, you will get through without uneventful any problem. If you are not lucky, you might end up with some complications. So I'll give you something else because you do not want. Whatever I give will not be zero pain. So when you come in follow up and say, Doctor, I still have a pain, I'll say, I told you, you should go for TKR. Why you are expecting this? Zero pain will not happen with all these things. So how do we teach them? Two things are very important. If the grade 4 is having a fixed flexion deformity, then that patient with a TB avara is not going to give you any good result. But both are negative. Fixed flexion deformity of 5 degree or 10 degree and TB avara is a mechanical stress. And now developing those muscles is not going to stabilize that. So you have to tell them either you have a braces or you can use this. Now all those patients, I give them evidences like to whom I have given. Now to whom we should give, all those patients who are considerate enough, who are having a high tolerance, who understands everything, who knows. So ultimately, it is not your scientific evidence which is going to work, it is the satisfaction of the patient. So if the patient is satisfied, then satisfaction comes when you explain a lot. But all those patients which I feel like that they are expecting a lot out of this, I simply tell them that it is not for you. Don't go for this.
Okay. If I
Now,
ask this,
one more thing which is
yeah,
very
please.
important. One more thing is very important. I get grade 3, grade 4. And I get almost 20% of them which I have seen them before 3 years or 5 years or 7 years. And that is the time where I tell them that look, I was telling you at that time you missed this. So you have missed the bus. And the second part is very important. Again, all these talks of orthobiologics or anything without TKR must include a sizable amount of your talk on exercise, exercise, exercise.
Rehab.
So all those patients who has done like this, what I tell them is that something which is going to be rotten, and I told you that please go with the anime, lamination or color, and then you say no, let me see if it gets rotten, I'll do something. Then it has already happened. Now if you come back and if I give some lamination, some lubrication, it is not going to heal the previous one. It will only stop the additional. But surprisingly, many patients for more than 15 years, 16 years, they are taking hyaluronic acid regularly, and they now tell me that I don't think I need TKR. So that happens. So
Oh, so
multiple
sir,
things
I,
happen.
I agree with your point that exercise is the key. Let it be TKR or HA or anything. It's like any car you have, let it be Maruti 800 or a BMW. Petrol is essential. So exercise the petrol for the muscle. So coming to Dr. Madan, if I have to pitch a same question, Dr. Madan, are you there?
Yes, yes.
So if I have to pitch the same question, see, we all are orthopedic surgeons. So I'm not talking about the early or moderate osteoarthritis. I'm talking about severe osteoarthritis when we have a proper grade for osteoarthritis and a varus or valgus deformity. So what is your take? As Dr. Jawahar said, you echo with him, or you have anything else to offer, or you will straight away go for knee replacement surgery?
Depending upon the age, if the age is less than 50, correct the mechanical alignment, then we'll give couple with orthobiologics modality. As Jawahar sir told, we'll offer the hinged knee braces exercises. This is the first line. If the patients are above 70, then if the patients are fit, then I'll go for TKR. If not fit, then we will offer the different levels of modalities are available. You can take any one of these and we will document in the I mean, their case sheets or whatever. The patient has been offered for TKR, patient denied, then following therapies have been informed to the patient and it has been given, depending upon the patient choice.
And what is your clinical experience about those patients after documentation also? What is your clinical experience about their pain management of those cases? What is your take?
If we are going ahead with pain management, yes, we can give multiple doses. I have given also with gross varus deformities of more than 15 degrees also we have given for maintenance. But we will clearly tell them that this will work only as a pain relieving modality and you can get multiple shots since it is an autologous PRP. But regarding stem cells, we have given only few patients in grade 4. Otherwise, in grade 4, we have avoided.
Sounds good. So, Dr. Jawahar, you had a question with Dr. Madan, right? So,
Yes,
please
yes.
go ahead, sir, Dr. Jawahar, sir.
Before that, let me tell you, any patient having a tibia vara significant, don't advocate anything else than upper tibial osteotomy because mechanically nothing is going to correct it. No amount of hyaluronic acid, no amount of medicines or polypeptide or anything. It is a mechanical thing. So tell the patient at the age of 40, 45, 50 years that better you get your alignment perfect. And second part in the part of exercise is do not forget to stabilize hip joint. The best exercise is first stabilize hip joint. Get the tone of flexors, abductors, adductors and extensors of the hip. That makes a fantastic thing, fantastic result on knee. And we usually concentrate on the knee exercise only. So that is very important. So my discussion with Dr. Pradhan was that regarding the relaxometry. So it's a new way of all the scientists to find out that what is happening inside. And we had been fortunate to have this thing, MRI, where we have point out the craters before surgery, the XY axis where was the crater, and from the same crater we have taken biopsy in the later part. With the same point of crater, we have gone through relaxometry of all these MRI findings, and we could find out that that is the region which has increased in the size. Now, increasing in size of the cartilage is very well known, but the finding out the quality of the cartilage is through relaxometry.
Dr. Madan, your talk on relaxometry?
Yeah, same
Where?
sir. Relaxometry. We are right now we are doing the study on this. Like from past 1 year, we are doing that relaxometry studies. Before that, we were doing only T2 cardiograms, which I have shown already. Relaxometry study maybe in another 1 or 2 months we will wind up the study and we'll may send for publication. We are doing sir already.
Yes, and the second
Nice,
part which
nice.
we are doing, the good way of finding out whether patient is helped by your methodology is to find out his gait. So we have developed a Bluetooth device where we apply something like a sticker on the different part of the legs and we get a gait study. So pre STO and post STO. Once we know that the gait has improved, that means it has worked. For patients who are limping, and probably not much of the literature is talking about the difference in gait after any of your methodology. And that, if we compare, it makes a big difference. So that is also an important point.
Interesting, sir. So, what Dr. Madan said that we in orthobiologics we know there is a lot of potential. We know it is going doing good, but we do not have a standard protocols or a big clinical Indian trials. So, thank you, Dr. Madan, and there are many other scientists. I am associated with them that we are planning to take it on a massive scale. Almost 200 plus centers are coming together to start clinical trials on different modalities and indication of orthobiologics. So maybe in another year or so, we will have a a huge Indian data which will guide everybody, including all orthopedic surgeon and pain doctors, whether this particular modality is good or not. So I request Dr. Jawahar sir to include his center for this orthobiologics trials. Dr. Darshan is here, and
Yes.
there are so many because almost 200 plus centers are already there. So we are targeting around 500 plus centers so that we can actually have a good conclusion, because orthobiologics still in 2025 in August we are sitting is still running on emotion, and we need to come out of that point. When we do nailing, we know the indication, contraindication. When we do plating, we know indication and contraindication. When we do arthroscopy, we know what is good and what is not. But orthobiologics still is going on with the emotion and the personal experience, what you say, because they say ki it is doing good with me. But if my colleague cannot reciprocate that particular technology, then that is not evidence-based medicine. Maybe PGI Chandigarh have made what you say superdose PRP, but if a colleague sitting in Delhi or in Chennai or in Pune cannot replicate that, we cannot say it's a evidence-based medicine. So we have to have a universal way of a product so that everybody, a qualified orthopedic surgeon, can reciprocate similar things. Maybe the result can vary, but the product should not vary. So then now with this thought, I hand over the further conversation to
I
Dr.
have one
Darshan
point.
to give his closing
Yes, sir.
remark. And before that, Dr. Jawahar is saying want to say something.
My point is that I have not gone through in detail of all the publications by Dr. Pradhan, but in the matrix there has to be a mention of degree of Varas.
Yes, sir, we have given, sir.
That is very, very important because
Yes.
everything will make a big change if the mechanical axis is not corrected. So I think it is a good way of finding out more, and the multiple centers always the better.
Yes.
I agree. Right.
One small comment, sir, for all the audience who are there for our webinar. Only thing is the evidence only each and everyone document and publish as a literature. Otherwise, the evidence won't get developed at any point of time, and no one will be knowing what people are doing. So many people are working on it, but the right way and to expose it to the scientific environment, then it will create a huge difference. That's the reason why India is lagging behind with publications. Everyone is doing a lot of patients, but they don't have time to sit and draft this. That if everyone start drafting their own data, then India will have a huge data right now. So my only humble request is all practicing orthopedic surgeons try to publish their data on orthobiologics, then we will have a huge data over globe. Thank you.
Yes, sir.
Very
Good
rightly
comment,
said,
sir.
Dr. Darshan.
I'll also have a few questions, sir, just to Dr. Jawahar, sir. So a patient comes to, as Dr. Karun sir mentioned, whether it is grade 2, grade 3, grade 4, any grade, patient comes to you, how do you choose whether you want to give a corticosteroid injection, depomedrol, or you want to give a hyaluronic acid injection?
Okay.
Is it based purely on the financial status of the patient, or there's some logic, another scientific basis to it?
So number one, I do not give steroid.
Okay.
Even
Never
I
ever.
don't give steroids.
Okay.
It's a full stop of not asking the patient. Only in one patient I have given this signal, which is containing steroid. And
Single.
that patient
Okay.
was having a grade 4 where she was not able to stand up. She
Mhm.
wanted to attend one ceremony, marriage
Okay.
ceremony. For
Mhm.
that only, that was only one patient. But very
Okay.
important aspect is explanation, checking the patient thoroughly, teaching them all these exercises, and counseling them for if there is a varus deformity. Then
Correct. Correct.
only it is work. So my point is like I see 50 patients. I explain to around 30, which I feel like. Out of 30, 5 will show some interest and only one will come for injection.
Correct.
And I never ever give injection on the day one visit. I tell them go
Correct.
back, understand, come back,
Correct.
and then only I'll give. Otherwise, it will be headache for you.
Correct.
You
Correct. I
give
mean,
and they will
counseling the
expect a lot
patient
of things.
is
Yes,
very important. I
very,
agree
very
with you,
important.
sir.
Yes, yes.
But having said that, I mean, I some of my patients I do give corticosteroid injections, and they give reasonably good results. I mean, I wouldn't recommend repeating the injections, but at least one dose. I mean, I wouldn't consider it too bad, especially with considering the financial aspect. many of the patients who do come, if they are not very affording, then instead of just sending them back and say either you take hyaluronic acid or don't take anything, is it
No, no,
worthwhile
that is
giving a
It is
single dose
worthwhile.
of
I tell you
corticosteroid?
why you are getting results. I tell you, you must be also asking them to do exercise,
Yeah, yeah, absolutely, absolutely.
right? Now, what happens? Why patients are not able to do good exercise? Because there is a pain.
Correct.
Why exercise is important is for the tone of the muscles, for the health of the cartilage, for the health of the ligament. Now, very important part you have to see is that when you do exercise, the ligament becomes stronger and they can supply good nutrition to the joint. Okay, and also some perfusion because of the sponging part. Now, once you give steroid, they are able to do better exercise, and doing better exercise is giving you little long lasting result. So it
Correct.
is ultimately exercise which is painless, and that's why they are doing it. So that is
Correct.
very important. That is very important.
Similar question to Dr. Madhan sir also. I mean, when a patient comes to you for any grade, I mean, one, two, three, not one, two, three, four. So in these patients with the plethora of various orthobiologics that are available, how do you make a choice that you will give, let's say, Goldic, or you will consider PRP, or you will consider some other stromal vascular fraction or liposuction? So how do you decide whether you want to give this modality or the other modality?
The first thing is I never recommend blood-based orthobiologicals because those doesn't have any cells. They are
Okay.
just only growth factors and signaling molecules which will act upon the cells. So the first dose I'll always recommend stem cells in form of BMAC or SBF. I'll give
Okay.
the patient's choice based to their own choice. And sometimes I'll take a decision because if a lean patient comes without any abdominal tissue, then there is no point in convincing him for SVF, adipose
Yes.
therapies. Then that patients I will only directly tell for you BMAC works better. Otherwise, I'll give the choice to them like a cafeteria approach. Once they pick up their choices, then I will tell them the subsequent doses should be only with the blood-based biologics. Because there are cells, already we have given cells. Now we are going to give a booster dose, boosting effect. At the time, I'll give only 2 or 3 doses of blood-based biologicals. It can be of anything like PRP, PRF, Goldic, anything, whichever the patient wants. Again, I'll give the patient's approach and the cost of factor available with that particular modality. Whatever the patient chooses, then we will go ahead with it. And I'll explain even the benefits and the disadvantages of that particular modality also.
Correct. Correct. Great. Great.
I have only
Yes,
one
sir.
question for Dr.
Along with
Pradhan.
that, exercises also.
Okay. So my question is, Dr. Pradhan, is that I have heard that there is a blood test which is called live platelet count. Have you come across that?
What is that, sir?
No, live
So there
platelet
is
count. These are the
one.
indicators. Live platelet count and platelet width. These are the indicators for the quality of platelets. If we are injecting platelet-rich plasma, then we have to see all these things. But if we are injecting platelet-rich fibrin, we can't measure the platelet in that fibrin gel. If we are giving GFC or any other modality, no need to bother about platelets because we are bothering about growth factors there.
Only.
But whatever sir has told, I have never done it because it is a little higher cost factor
Yes.
where no other labs are doing, only research labs, they are doing for the research purposes.
Okay. Okay.
Imagine we are four orthopedic surgeon and we are totally engaged in 1.5 hour of discussion. Imagine a whole hall full of orthopedic surgeons. We have 200 plus
Absolutely.
orthopedic
Absolutely.
surgeons. So imagine the time and the discussion deep details we will have. So this itself shows the potential and the interest of the orthobiologics. And I think we are heading towards the right direction. And with this, because Ortho TV has a limitation till 9:30 p.m. So, Dr. Darshan, we would like to have your closing remark on that. And
Yeah.
before you give a closing remark, a very cheerful thank you to Dr. Jawahar Jethwa sir and Dr. Madhan to take out their time.
Thank you, one and all for attending the session. Thank you, Jawahar Jeta sir, Dr. Madhan sir, Dr. Karun Jain sir, as always. So we had a great session. It was a great learning experience. We understood a lot of things. I mean, what is the rationale behind using various modalities for osteoarthritis? I mean, something that is tramadol, I mean, which is being used very commonly, rampantly, tramadol is being used. But as we saw, Java sir mentioned that it is not recommended at all. I mean, it's not a good thing to do. So that is one take home message for all the young orthopedic surgeons, everyone here, in fact, that please do not use tramadol left, right, and center. Use the other things, as sir mentioned, pulmocoxib, bitodolac, which is Carely Pure, or the other modalities. And of course, I mean, physiotherapy is the baseline. I mean, nothing else, only physiotherapy will work. You do anything else, don't do anything else, physiotherapy is mandatory. Of course, various surgeries, I mean, other than TKR, high tibial osteotomy, as we mentioned, I mean, mechanical problems require mechanical solutions. So if your tire is punctured, you cannot say, I do not want to remove the nail in the tire. So that's the analogy I usually give to my patients. So I tell them, if your tibia is bent, I mean, it's like a nail that has gone in your tire. And if you tell me now, don't remove the nail, then all I can tell you is you need to fill air repeatedly. There's nothing else that we can do. Apart from that, orthobiologics, it's a plethora. I mean, it's a Pandora's box. There's so much to still explore, and there's so much, I mean, the possibilities are sort of endless. So it is something that, as Dr. Madhan mentioned, each and every one of us, it is sort of our duty to gather, collect data, and publish it one way or the other. I mean, if you're unable to publish it individually, maybe collaborate with others, your seniors, your friends, colleagues, someone, and try and publish the data. I mean, each bit of data is very precious. And as Dr. Karun sir mentioned, he's planning a multi-centric collation of data with more than 500 centers. I mean, that will be great. I mean, the amount of data that we can collect, collate, and publish, it's just, I mean, incomparable. I mean, no other country in the world will be able to come up with these many numbers. So that's a great initiative by Karun sir. And with that, I would like to thank everyone for attending this session. Thank you, one and all, everyone, for making this a huge success. Thank you, sir.
Thank you.
Thank you.
And before we just say sign off, I would thank Ortho TV team,
Yes,
because
absolutely. Ortho
Ortho TV
TV
team
is
has
a
bought this on a national platform, and Dr. Madan and Dr. Jawahar Jethwa sir, just to highlight, this is the fifth episode of Orthobiologics, and every episode has been attended by more than 3,000 orthopedic surgeons. So that number speaks the amount of interest what orthopedic surgeons have. So 3,000 plus every time we have the audience attendance. So with this, I request everybody to stay tuned. We will have a sixth episode, and we will come up with another modality, another indication of orthobiologics and evidence-based science. And then with this, we sign off for this episode of the fifth episode. Thank you, Dr. Darshan,
yes.
Dr.
Thank you so
Jawahar
much.
sir, and my favorite Dr. Madan.
Yes.
Thank you.
Thank you,
Thank you.
Thank you,
Yeah.
sir.
Once
everybody.
again,
Good night.
thank you, Ortho TV, Dr. Ashok Sham sir, Dr. Neeraj Bishani sir, the entire Ortho TV team. It's a great
Thank
support, and
you.
it's a great platform for all the orthopedic surgeons all over India and across the world. It's a great platform.
Thank you. Thank you,
Thank you.
everybody. Thank you, everyone.
Thank you.
Yes. Thank you so much.